So we all know that in an EGFR mutant lung cancer, the PFS improves with EGFR TKIs compared to that of cytotoxic therapy, which has been well established. And initially, this was shown in various trials where a survival of 11 months compared over a median PFS of 11 months versus to 8.6 months was achieved. Osimertinib, as we know, is an irreversible third generation EGFR tyrosine kinase inhibitor, which showed a significant improvement in the median PFS in the FLORA trial. The overall survival was 38.6 versus 31.8 when
sorry for interrupt you, but your slide is not moving.
Slides are not visible.
It's not moving, sir.
Yeah, I'm on the second slide only. Now?
Can you please click on bottom? Click on slideshow button on top tab.
Sir, can you make it full screen mode, sir?
Yeah, I have actually, just one sec. It's on full screen on my PC.
No, sir. Can I share from my side?
Yeah, please do that.
Please stop the screen.
Okay, let's go to the next one. Next, please. So we know about the FLORA trial, which looked at the overall survival analysis of EGFR or osimertinib with the comparator EGFR TKIs as a first-line treatment for advanced NSCLC. Next, please. So we all know that it was a double-blinded phase 3 RCT, which took place from December 2014 to March 2016. And this was in 132 sites across 29 countries. And initially 994 people were screened, out of which 556 were finally eligible for the study. And those who were above 18 years with a good performance status and having exon 19 deletion or L858R rearrangement were tested. They should not have had any prior systemic therapy, and stable CNS mets were allowed. They were stratified by their mutation status and the race, being Asian and non-Asian, and osimertinib in the doses of 80 milligram daily was compared with the comparator first generation or second generation TKIs of geftinib of 250 milligrams or erlotinib of 150 milligrams daily. The response was assessed at 6 weeks initially until disease progression, and then thereafter after every 12 weeks till the endpoint was met. The primary endpoint was PFS, and the secondary endpoint was overall survival. Next, please. The baseline characteristics were well matched as far as the study was concerned. The male-female ratio, the median age was around 64. There were more 60 to 40% Asians versus non-Asians, similarly in smokers. And at entry, CNS mets were found in around 19% compared to 23% in the other arm. Their performance status was good, and they all had advanced metastatic disease in 95% of patients, and 5% had it in locally advanced. The histology in almost all, 98 to 99%, was adenocarcinoma, and in others was large cell or mixed adenosquamous. The EGFR mutation were of these two types, exon 19 deletion and L858R in 60 to 40 ratio. Next. So you can see the primary analysis showed that the progression-free survival showed that the curves in the Kaplan-Meier separate early, and starting at 6 weeks, at the initial, only at 3 months, they have started separating, and this is maintained towards the end of this study. And as we see in the box and whisker plot, it favors osimertinib across all departments, as shown in the chart. Next. The overall survival was also seen to be 38.6 months versus 31.8 months. This was not significant. Next. So the FLORA showed that a statistically significant and clinically meaningful improvement in overall survival with osimertinib was there for EGFR mutated lung cancer. And we know that it acts against those EGFR mutated lung cancers which are TKI sensitive or which are TKI. We have a T790 EGFR mutation resistance to the T790M. So and it also has a consistent toxicity profile despite a prolonged exposure. And even after 3 years, 28 to 30% of patients in the osimertinib arm versus 9% in the comparator arm remained on the first line study of treatment. And this is a very encouraging finding. The final overall survival analysis reinforces that osimertinib or tarigaso, as the trade name is a standard of care for patients with EGFR metastatic advanced NSCLC. Next, please. Now, even the NCCN guidelines, as you can see, shows it as a preferred, once we direct an EGFR sensitizing mutation, it is the preferred line of treatment. And when we give another line of chemotherapy and then discover this mutation later on, it still remains as a first line therapy, which is indicated. Next, please. So now, why do we need real world evidence? We understand that as we do various studies like the FLORA trial or maybe other trials, these are very select population of people and they account for only about 2 to 4% of the patients who are highly selected subgroups. And we need to have something like a post-marketing survey, or we need to analyze what happens in the real world, which actually gives you a real picture of how the drug is acting across various subpopulations. So that is why real world data is a continuous kind of a data which can be collected and is significant to know. The 3 studies, the FLOWER, the OIC FACT, and the Mykonos, as we will just run through these. Next, please. So the FLOWER was the first line osimertinib in patients with EGFR mutant advanced non-small cell lung cancer. It's an observational multi-center trial, which a multi-center study, which shows the use of first line osimertinib. Next, please. So this took about 126 patients over 9 centers, and 64% were male, and 64% were females in this, and 36% were males. And what we looked here is at the median time to drug. So osimertinib, this we covered this. Just go ahead, please. Next slide. Yeah. So we had 126 patients, the median age being 68. About 70% of them were never smokers in this, and around 95% were having adenocarcinoma, adenosquamous, in around 1%, and it was unknown in another 1%. Importantly, about 30% of them had brain mets. They had exon 19 or exon 21 mutations, and they were in advanced stage. Next, please. The inclusion criteria were the standard inclusion criteria: more than 18 years, histologically confirmed diagnosis, a mutation in EGFR in exon 18 to 21, and locally advanced 3B or advanced stage 4 disease. And they were eligible to receive the first line treatment with osimertinib. Next, please. So we were looking at a pragmatic real world endpoint, and this was the TTD. That means time to drug, using the next drug. So if we see that the time to TTD affects the effectiveness of anti-cancer therapy in NSCLC, and we can use the drug beyond the RACIST or beyond some mechanical parameters of measurement. That means rather than looking at the length, breadth, and the width of the tumor, which may have had oligoprogression, which commonly occurs in oncogene-directed tumors, we also look at this figure, which helps us to, which may be slightly more than the PFS. The secondary endpoints were overall survival, the median PFS, the response rates, which is something which we really don't measure in our current in regular practice, and the disease control rate. Next, please. So those patients in the real world data who had poor performance status, they had a high Charlton comorbidity score, or they had rare EGFM mutations were included in this. Next, please. And there was found that there was the PFS and the TTD, time to discontinuation of the drug, were comparable. Next, please. Next, please. So the median time to discontinuation appears to be a suitable endpoint to evaluate the treatment outcomes. It was longer, about 25.3 months, than the post-progression outcomes of the FLORA trial, which were around 20.8 months, which was probably due to a study population which could not undergo further therapy or was different for oligoprogressive disease. A better, and just go back, please. A better TTD was associated with fewer than 3 progressing sites and compared with oligo or systemic progression. Next, please. And, so if we really look at the secondary endpoints, which are PFS, OS, next please, and disease control rate, the progression patterns we know in these cancers would be due to MET amplification or due to HER2/neu amplification or EGFR amplification. Next, please. So the median TTD is assesses anti-cancer treatment. It's a pragmatic real-world parameter. We can continue treatment beyond the racist and oncogene-erected tumors, which may have oligoprogression. It is and it justifies the tumor biology. So this is a good outcome to assess in the real world. And after a median follow-up of 12.3 months, the median PFS was around 18.9 months. The OS was not reached till the data cutoff. Next, please. And as we can see, this we have already covered. Next, please. Next. So in multivariate analysis, a longer PFS was noticed in the absence of brain mets. The prolonged PFS and longer overall survival was noticed in patients without symptoms at diagnosis. So essentially, those people did better who did not have brain mets or who had asymptomatic status, which is well known. Next, please. So the essential evidence of evidence-based medicine can help the clinician in decision-making rather than lengthy trials, which may not apply to across all population groups. Next, please. So the usual complications of nausea, vomiting, diarrhea, a dry rash, skin, pyronychia, pneumonitis was known. The worrisome part was the pneumonitis and diarrhea, which led to discontinuation. Next, please. Venous thromboembolism was another most common finding in the real world, and this needs to be further elucidated over various trials. And this is a worrisome complication. Next, please. Next, please. So no difference in survival outcome was there according to age, comorbidity, or type of EGFR mutation. And Osimertinib was effective in the real world scenario across all EGFR mutation subtypes. Now, there's another study, the OIC FACT, which looks at Osimertinib and its first-line treatment for advanced EGFR mutation positive NSCLC in the real world setting by Vaisataka. So we well know that Osimertinib is superior to first generation TKIs. Next, please. And in this, we saw that it was a retrospective study which included EGFR positive mutant advanced NSCLC with Osimertinib as the initial treatment. Next, please. The baseline characteristics were similar to other studies, that the median age in about 60-40 ratio was less than 75 and more than 75. And there were females who were the predominant in 60-40 ratio, 60% females and 40% males. And they were generally in a good performance status in more than 83-84%. And around 60% were never smokers, and around 40% were smokers. And the histology in most of the patients, almost all patients, was adenocarcinoma. The mutations commonly detected in around 50% were the 19 deletion and L858R in around 45-50%. They were all mostly in advanced stage. In 65%, they were in stage 4 and locally advanced in a few, and in the recurrent setting in 30%. Next, please. So the important part is that the PDL1 was also looked at, and for some reason, around they were stratified into 3 groups, where 30% had less than 1 PDL1 positivity of less than 1%, and 1 to 49% around 30%, and more than 50% were around 11%. Next, please. Yeah, go on. So the primary endpoint was the PFS, and the secondary endpoint was OSS, overall survival, TTF, response rates, and disease control rate, and the objective response rate. Next, please. So the progression-free survival occurred in almost 182 of the 538 patients observed retrospectively, and the median PFS was significantly 20.5 months, and the endpoint was not reached. Next, please. Yeah. Next, please. Other parameters which were associated with the progression-free survival were those patients who had advanced unresectable cases, those with liver mets, malignant diffusions, or male gender. Next. And when we looked at the PDL1 expression in the subgroup analysis, when the PDL expression was less than 1%, the PFS was not reached during the endpoint of the retrospective study and current observation, and it was 14.7 months with those who had less than 50% PDL1 positivity, and 11 months for those with a PDL1 status of more than 50% or more. Next, please. This we've already covered. Next. So we all know that Osimertinib also causes some symptoms like fatigue, anemia, QT prolongation, skin disorders, which is well known. But the discontinuation was widely due to either pneumonitis or, as can be seen, due to disease progression, which progression was due to either EGFR amplification or a new mutation of MET, or conversion to a small cell histology, or due to MET amplification, which I've covered, or a HER2 new amplification. Next, please. So pneumonitis is a very worrisome complication in this drug, and when it happens, in my experience, we have been, and in the real world experience, we have not been able to recontinue the drug. The cardiac issues are there, but not seen very often other than a QT prolongation, which may lead to a stoppage of the medication in a few patients. Next, please. Next slide. So to conclude, the overall response rate was around 76%. The disease control rate was fairly good, about 94% in those patients. And all of us, as we have seen in the real world, when we use Osimertinib and when the patient can afford it, it gives an excellent survival and progression-free survival, irrespective of its PDL expression, one expression. The median time to failure was around 19.1 months. And the adverse effects mainly were manageable, except when the patient developed pneumonitis or a cardiac complication. So in the real world, PFS after Osimertinib was favorable, and discontinuation rate was around 18 to 20%. So the MICON's real-world study of patients was the third real-world data with EGFR mutated. It did also include locally advanced patients or metastatic NSCLC treated with first-line Osimertinib. So we have seen in the FLORA trial the PFS advantage of as good as 8.7 months while using Osimertinib in first line in this subgroup of patients. And we're also seeing the 3-year data of overall survival, which is very encouraging to use it in the first line. There remains a need to evaluate the real world disease characteristics and outcome of patients with EGFR mutated NSCLC treated with first line Osimertinib therapy. So the study design used a global observation prospective cohort across the Europe, USA, and Asia, and involved looking at electronic health records from various places. In the US, sub-analysis from the Flatiron Health Electronic System was de-identified, and the structured level and unstructured data was obtained from here. During the study period, 280 US cancer clinics and 800 sites of care were involved. And during this interim sub-analysis till 30th June 2020, this is an ongoing study and is planned to end in somewhere in June 2023, which included the same subgroup of locally advanced or stage 3B or 4 EGFR mutated more than 18 years, males and females, to receive first-line Osimertinib from 1st April 18 to 31st March 20. Next, please. Next slide, please. Yeah. So the baseline patterns and treatment patterns were summarized during descriptive statistics. The Kaplan-Meier analysis was used to study TT-NTD. That means time to next treatment and or death. There's time to next treatment or death and time to discontinuation. The real world time to next treatment or death was defined as the index date from the start of next systemic therapy or death in the absence of systemic therapy. So more than the PFS, by the time, supposing we do a PET scan to reassess end of treatment, this gives us few months more till the time the patient goes into the next systemic therapy. So it'll almost mirror image the PFS, but maybe a few weeks or even months more than the PFS. So this helps us to ascertain the status. The real world time to discontinuation is from the index date to the earliest end date of Osimertinib with discontinuation of prior end of first line therapy. And what we have seen is, although I have not mentioned it earlier, but a few of my patients in my own experience have discontinued the drug due to thrombocytopenia, which was common in, I just have a small 4-5 study, but this was worth mentioning. Next slide, please. So as we can see that most of the patients were
Sir, sorry to interrupt, but you have last 2 minutes to conclude, sir.
So as we can see, from 18 to 75 years, there was almost 1/3 in all these 3 groups. The females were 70 to males were 70 to 30 ratio. There were Asians and non-Asians in this observation study. Next, please. And mainly they are Western data compared to the Asian people. And around 97% were non-squamous. They have also seen around 1%, I don't know why this was included as a squamous histology. Around 56% were non-smokers. And the comorbidity, Charlson comorbidity index included mostly people who are not having comorbidities. So this was a relatively healthier group other than the index disease. Next, please. The EGFR mutation was there in all patients studied, 548, and they were distributed as follows: around 50% per exon 19 deletion, LR858 in 33%, and uncommon mutations in 4%. Next, please. During the interim analysis, 58% continued to have Osimertinib therapy. Around 18% received second-line treatment due to progression. 18% patients died while on first-line treatment. and 4% of patients discontinued first-line treatment. Next, please. The median follow-up was around 9.6 months during the current interim analysis, and the real-world time to next treatment or death was 17.9 months. Next, please. The following variables were associated with RWTT-NTD, which means the stage, the smoking status, the Charlson comorbidity index, the mutation type, and number of metastatic sites if there were more than 4. Next, please. The median time to discontinuation was 17.2 months. Next, please. Both the data are comparable. And in the multivariate analysis, this also correlated with a similar picture to the RWTT-NTD. So the study provides insights into the first-line Osimertinib in advanced NSCLC, which are EGFR mutated, in the US subpopulation. The interim results support the effectiveness of Osimertinib in this real-world population. And finally, in June 2023, long-term outcomes will be evaluated, and I'm sure they'll be encouraging. Thank you for a patient hearing.
Thank you, sir, for those wonderful insights on the role of Osimertinib even in the real world setting, about the efficacy and also the safety profile. Thank you once again, sir.